At Des Moines University Clinic, you'll find healthcare professionals with only one priority: you, the patient. Come see us for the very best in family medicine, physical therapy, podiatric medicine, and osteopathic manual medicine. Call today to schedule an appointment.
Well, hello everyone. My name is Sean Grambart. I'm an assistant professor as well as the assistant dean of academic affairs at Des Moines University within the College of Podiatric Medicine and Surgery. Welcome to an ankle portion when we're talking about DMU being 50 and better. So the topic that I chose is total ankle replacement. This is something that's becoming more and more prevalent, and there's quite a bit of new information that's coming across, as well as where we've gone from a historical perspective regarding this particular procedure. When it comes to end-stage ankle arthritis, this is a pretty unique disease. This is different than hip arthritis and knee arthritis. And there are a couple of reasons why. When we talk about ankle arthritis, oftentimes it's due to a traumatic injury, someone that broke their ankle, some kind of cause. It could be rheumatoid arthritis, for example, but usually it's due to a traumatic injury. There's often adjacent deformity, which means maybe the ankle joint's not in perfect alignment. There can be an injury to the tibia up or the leg bone itself. There can also be a injury to or a deformity of the joints below the ankle. And these surrounding joints, the joint below the ankle and the joint in front of the ankle, can affect our surgical decisions as well, compared to a hip or a knee, which are large joints with very minimal joints surrounding them. The age of the patient can be unique when we talk about ankle arthritis compared to hip and knee arthritis, and then what the expectations are. And all of this affects the way that we make our treatment decisions for patients. When we're talking hip and knee arthritis, the biggest difference is knee arthritis, for example, is a primary arthritis. This just occurs as time goes on. There's no associated factor with it. It is the most common primary arthritis. As you can see in this particular slide, post-traumatic osteoarthritis is very, very small percentage. Non-post-traumatic arthritis, meaning it just happens, is approximately 90%. So that's going to be the difference when we talk about knee arthritis versus ankle arthritis. Ankle arthritis, almost 80% of arthritis that forms in the ankle is due to trauma, post-traumatic osteoarthritis, PTOA. Non-post-traumatic osteoarthritis is about the remaining 20.5%. And this can be due to hemophilia, rheumatoid arthritis. Different congenital conditions can cause this. So this is typically a secondary arthritis, or one that occurs due to some type of event. And it takes time to develop. Different fractures, when we talk about post-traumatic ankle osteoarthritis, it takes different amount of time. So when you look at these particular numbers, the malleolus is the inside ankle bone or the outside ankle bone, for example. When we talk about fractures in time, we're talking a pretty significant amount of time, months for this to develop, years. So 35 months with ligament instability, 25 months for it just to start to develop, and that can get worse as time goes on. So end-stage ankle arthritis is more of a disease of the young. More younger people injure their ankle, and as time goes on, you start to develop arthritis of it. So when we look at hip and knee arthritis, that average age is closer to 70. Ankle arthritis is a younger type of arthritic condition, closer to the age 55. And we know that there are millions of people, approximately 2 million of people visit their physician or surgeon due to ankle pain from either arthritis or from a fracture on an annual basis. So this kind of fits into the group that we're really looking at, is that 50 and older patient, the younger patient that develops arthritis in their ankle. there's a small percentage of these patients that have normal alignment, and what we mean by normal alignment is it looks perfectly aligned. We don't have to do anything to realign it. You can see in this particular x-ray, as you look here, if we draw a line, you can see how you get this big bowing of the tibia coming down here. So that's a malalignment. We are usually doing some type of adjacent procedures to the joints or to the bone with ankle replacements, and that's rarely ever required with knee arthritis when you're doing a total knee replacement or a total hip replacement. And that's what makes the ankle arthritis more specialized. So hip and knee joint replacement surgeons typically do not do ankle replacements because it's such a unique type of joint that this is usually dealt with from a foot and ankle surgeon standpoint. And looking back on it years ago, and we're talking 15 to 20 years ago, the outcomes were less predictable. Now, as we've improved, which we'll talk about in a little bit, is we have more predictable outcomes that actually rival the numbers of hip and knee replacements. So we are getting better as time goes on. At this point, we're equal to what hip and knee replacements do from a predictability standpoint. There are a couple of different options when you have ankle arthritis that is not common in the hip and knee. So the gold standard that we talk about is fusion. An ankle fusion is when you put the ankle together. Let's say if you have significant arthritis, the gold standard that we've been doing for years and years and years is fusing the ankle together. So you will lose mobility of the ankle joint, but by not having a joint, you won't have arthritis. Ankle arthroplasty or ankle replacement is the newer option, and realistically it's several decades old at this point, but it's a more common option at this point, and we have seen outcomes comparing ankle fusion or ankle arthrodesis to ankle replacement, and they have identical, very, very similar patient outcomes according to the latest literature on it. So this is an example of an ankle fusion. You can see if you look at, so the ankle joint would be right across this area here. With arthritis, you have a plate that comes across this area and screws here and here that have fused the ankle together. So the gold standard for years has been make the tibia or the leg bone and the talus or the ankle bone one bone to eliminate the joint. And that has worked for years, especially prior to the success of ankle replacements. But now we've got the ability to actually look at replacing the joint. So you can see we have two different ankle replacements here. You have the metal piece that goes into the tibia or the leg bone here and here. You have the piece that sits on the talus. Consider the talus the bone. I kind of call it the quarterback of the team because it allows the foot to move up and down and side to side. So here's the component on the talus, and then you have this ultra high molecular weight polyethylene piece that goes in between the two components. That's kind of like a brake pad, and we'll talk about this in a little bit, but that's a piece that at times you have to replace every once in a while. But that's the newer options that we have. And we basically got to ankle replacements because if you do a Dr. Google search, as I like to call it, people aren't happy when they have an ankle fusion because they lose motion. There are some people that ankle fusion is 100% indicated for, that I wouldn't even recommend an ankle replacement. But there are some people in which an ankle replacement is an option. So if you fuse the ankle, you're going to lose motion across there. And that puts stress on adjacent joints, and people aren't happy that they lose the motion. Ankle fusions also have a fairly high non-union rate, and what that means is the bones don't fuse together, which can be a pretty problematic complication. You can see on the CT scan here the joint line is still visible, so a non-union can be painful. You typically don't get that with an ankle replacement. And you can get increased juxtaarticular or increased arthritis, the joints below the ankle here and the joints in front of the ankle. So you will put more stress on those particular joints. So what's changed? Well, the biggest things that changed is we are getting better with ankle replacements. Technology has improved significantly. You can look at the ankle replacement that we were putting back in the 1970s. You have a component in the talus. You have this kind of polyethylene piece in the tibia, and that's it. To compare to where we are now, 2009, we have these solid pieces that hold up well. There's that question of ankle fusion remaining the gold standard. More and more studies have shown that they have very similar patient satisfaction rates from an outcome standpoint, and we know that the ankle replacement maintains motion, so we're seeing more and more patients that are happier with the results from the ankle replacement. Sometimes, and you can see here, here's a fusion that successfully healed, but we had to take down the outside ankle bone to actually access that, and that's been going on for years and years and years. There's a sample of a replacement, the newer ones where we use smaller components that go into the leg bone or the tibia, so we're not having to resect as much bone. So the history behind it, we've been doing ankle replacements for more than 40 years. Early 70s is when the first ones came out. They had a high failure rate. Okay, it's greater than 50% failure rate, did not hold up well. And now we've gone through multiple generations to improve the design of it, which has made it last longer and become more predictable. So with an ankle replacement or a TAR, total ankle replacement, the question that will always get asked, can you really salvage motion? Can you get motion back? And the primary purpose to do an ankle replacement is to alleviate pain. Okay, hands down. If you say, why are we doing this? We are doing it to eliminate the bone-on-bone arthritic pain. Post-op motion depends on how much stiffness you have before surgery. So if you have a very stiff ankle joint where you have so much arthritis it really doesn't move that well, those are patients that I would recommend an ankle fusion because you're functioning with the fusion to begin with. However, if you do have motion there, an ankle replacement will give you what you have in a little bit more. So you actually get closer to normal motion with an ankle replacement once it heals properly. So that's where the key is. Our first generation ones, just to go through a little history, we don't do these anymore. You can see these are very old pictures of it. I took one out probably 15 years ago, and I'm still trying to find the picture of it. It just kind of fell out of someone's ankle, but it actually lasted for almost 25 years in this patient. So I would consider that a success, but these were very unpredictable. The second generation, these came around in the late 80s, mid 90s, and lasted till the early 2000s. You can see we had multiple screws. You had these big components that went across the outside ankle bone and the inside ankle bone. They helped, but they had a tendency to be a little bit unstable. They loosened a little bit. So we probably saw about 75% success rate with these. Third generation is more stable components. This is where we made a huge leap forward, where we're seeing 92 to 94% success rate with these. We get bony ingrowth within this metal component. This is the tibial component on top, talar component on the bottom. There's that plastic piece or the ultra high molecular weight polyethylene that goes in between, and the bone actually grows into the components now. That's what those little pores, kind of the rough surfaces, are meant to do. We have ones that can go up into the tibia, and that's for more stability. We can do it for deformity correction as well. So we really have made significant improvement with these. Our fourth generation, or the newer ones that are out now, are made of a different ultra light polyethylene. It's a significant improvement. It's stronger. It creates less wear and tear, so we don't have to replace those as much. The biggest thing that we've seen is CT planning. So we can actually make custom guides to help for an individual patient, we can take a CT scan and develop a custom guide for that particular patient. So this is an example of what it looks like. After we get a CT scan, we can make an exact design that when we are in the operating room, we have, so this is the sample of the tibia, and this is a sample of the talus. That's made from the CT, and that's actually in the operating room with me. And then we create this custom-made cutting jig to help line everything up. So everyone is different. This 15979 is specific for a single patient. And we can put this directly on the patient to help prepare our cuts. So this is a very, very, very precise cutting guide. It has cut down the operating room time significantly and has improved our outcomes tremendously with this. Before, ankle replacements would take about 3 hours. If you get into an experienced surgeon's hand, they take about an hour. So the ideal patient, 50 years old, low physical demands. These are not patients that want to get back to running marathons. These are patients that would like to walk to golf, work in the garden, walk their dogs. That's what we're looking for. They're healthy, they have reasonable weight, they have good alignment, and they've got good blood flow. Patients that are not ideal are patients that have deformity that is significant, severe malalignment, diabetic patients that can't feel, we don't do these on, neuromuscular problems where we know there's going to be increased deformity as time goes on, and if you have poor blood flow. Okay, so this patient was done at an outside facility. They put it in on this type of deformity, and now we have this mess to clean up. So there are ideal patients and there are patients that are definitely contraindicated for this particular surgery. So poor skin, if you have trauma that we don't have a healthy soft tissue to make an incision, we won't do it on. Circulation is another big thing. And age, we try not to do it on young patients because we know that it's not going to hold up as time goes on. So the pros of ankle replacements, we can get close to normal range of motion. We can decrease the pain. You're able to move up and down more. The cons is you're going to probably have to have multiple surgeries. You have your first surgery, you get the components in, and then that plastic piece or the brake pad is probably going to have to be replaced at some point. About every 10 to 15 years, you're going to have to put a new one in. So you're going to have maintenance procedures. You can get subsidence where the components will start to slide down, and you may have to convert it to an ankle fusion, which is a huge procedure. And then the recovery is significantly different. I think that's the biggest thing is when people come in and said, oh, I've had a hip replacement done or I've had a knee replacement done. An ankle replacement is totally different. Hip and knee replacements, those joint specialists get you moving basically that day. With an ankle replacement, you are typically non-weight bearing on it for 4 to 6 weeks, similar to a fracture, and you're in a walking boot for another 4 to 6 weeks. So it takes time to recover from this one. It's not immediate weight bearing. And we oftentimes will have to stage this, where we'll have to do multiple procedures to realign the hind foot and then put the ankle in as well. So here's a case. You can see a pretty straightforward ankle replacement. That spot in between is where the plastic piece or the polyethylene sits. Here's one where we added a subtalar joint fusion because there's arthritis underneath it. And we have nice alignment here, so that's going to have full motion up and down. This is a non-union of an ankle fusion. So the ankle fusion did not heal properly. We were able to convert it to an ankle replacement. That can be done at times as well. Here's one with some malalignment. You can see the angular deformity here where it comes out to the side. We can actually realign it by cutting into the tibia. And then this is a staged procedure, so we realign the long bone of the leg to make it nice and straight. And then we put the ankle replacement in afterwards, after a couple months to allow that to heal. So in conclusion, ankle replacement is definitely, there are more and more being done. We are getting very good at them. and an experienced surgeon will do very well with these, and they'll tell you if you're a candidate for it or if you're not. We look for the perfect patient. We look for that over 50, someone that just wants to do low impact activities. We do plan for multiple surgeries with this because we know we will likely have to do some maintenance procedures on it. I would consider an ankle fusion if you're a one and done person. If you don't want multiple surgeries, ankle fusion is something that you should do instead, or if you have very, very, very limited range of motion, you're better off with an ankle fusion. Ankle fusion's one and done. Ankle replacement is multiple surgeries, and that's a big, big key as people look to this particular procedure. And that is all I have for you. So hopefully if you have any questions about this, or if you think you're a candidate, or just even like to discuss some ankle pain that you have, please feel free to contact Des Moines University Foot and Ankle, and we can certainly give you some options on it. So thank you for your time.
At Des Moines University Clinic Foot and Ankle, our expert providers provide comprehensive care for older adults who often have compounded foot and ankle issues. The Foot and Ankle Clinic has the largest group of board-certified podiatric physicians in central Iowa. As a teaching clinic, we're training the next group of podiatric physicians, which means that our clinic offers the most advanced care in foot and ankle possible. Doctors of podiatric medicine are specialists in the diagnosis, treatment, and care of lower extremity disorders, diseases, and injuries. Our physicians diagnose and treat conditions such as ulcers, tumors, fractures, skin and nail diseases, injuries, as well as deformities and conditions such as weak feet and foot imbalances. We use innovative methods to treat many conditions such as ingrown toenails, calluses, fractures, other injuries, as well as arch problems and bone disorders. At Foot and Ankle, we offer thorough consultations for both preventative care as well as diagnosis and treatment of many conditions involving the foot and ankle. No matter what foot and ankle issue you're dealing with, know that a team of specialists here at Des Moines University Clinics is willing and ready to help with whatever needs you may have.